This is just the definition of two structures that I showed you on the figure. The interatrial septum. A septum is a divider that separates. So the interatrial septum separates the two atria, and the interventricular septum separates the right and left ventricles. Okay. The coronary sinus receives deoxygenated blood via the cardiac veins from the myocardium of the heart. So basically, when the aorta delivers oxygen-rich blood to all the cells of the body, the heart is an organ that needs oxygen as well. The muscle cells and all the tissue cells of the heart need to be supplied with oxygen. So the coronary blood vessels, the coronary arteries and veins, are going to be the ones that the arteries supply the blood to the heart, and the veins drain the blood from the heart so it can go back into the heart chambers and be pumped to the lungs to get more oxygen. So the coronary veins, the blood from the coronary veins, all of that blood ends up in this open area, or this kind of bulge called the coronary sinus. So the cardiac veins drain into the coronary sinus, and then that blood drains into the right atrium, along with the blood from the superior and inferior vena cava. Now, I showed you the fossa ovalis, which is a small depression in the right atrium in the adult heart. But it comes from, in the fetus, there is an opening called the foramen ovale. And when that closes, it becomes the fossa ovalis. The valves of the heart, the ones that are called the AV or atrioventricular valves, are the tricuspid valve, which prevents the backflow of blood into the right atrium, and the bicuspid or mitral valve, which prevents the backflow of blood into the left atrium. Then we have the chordae tendineae, which holds the cusp of the valve. It connects them to the papillary muscles, which is on the inner surface of each ventricle. And those are necessary for proper closure of the valve flaps. The ligamentum arteriosum, remember, connects the pulmonary trunk to the aortic arch. All right, some medical type terminology, I guess you say, is we hear heart murmurs sometimes when we listen to sounds through a stethoscope. So these are sounds made by small amounts of regurgitation when valves don't completely shut, or there's maybe some type of, the valves are imperfect in some way. You also see muscular ridges. Now, the papillary muscles are connected to the chordae tendineae, but the trabeculae carneae are muscular ridges that line the ventricles of the heart. And this is just a picture that shows you the valves of the heart when they are open and when they're closed. In the top illustration, you can see the tricuspid valve and the bicuspid valve open, and then you can see the aortic valve and the pulmonary valve closed. And then in the bottom picture, the AV valves are closed and the semilunar valves are open. And you can also see what they really look like in a real heart. You know, this would be the aortic valve closed and open. Differences between the two ventricles. I already told you the left ventricle is larger and more muscular, thicker. And that is because the left ventricle has a very thick myocardium and produces 4 to 6 times as much pressure as the right ventricle. And that is because all the right ventricle has to do is pump blood directly to its left and right, which is the left and right lungs. But the left ventricle has to pump blood, to the top of the head all the way to the tips of our toes. So it's going to take a lot more pressure to do that. And so that's because the left ventricle pumps blood to the systemic circuit and the right ventricle pumps blood to the pulmonary circuit. Our semilunar valves are the ones that prevent backflow into the ventricles. So there's a pulmonary semilunar valve, or you could just say pulmonary valve, that prevents backflow into the right ventricle. And then the aortic valve prevents backflow into the left ventricle. All right, now we have the coronary circulation, which I honestly did not ask a lot of questions about this. You may have some in your lab activities, but I'll just point out some of the major arteries and veins that you might would have to know if you're working in cardio medicine. So we have the left coronary artery here, and then the circumflex artery, which goes all the way around behind and kind of encircles the heart. And we have the great cardiac vein, which is found in the interventricular sulcus between the two ventricles. You do need to know this term anastomosis. Anastomoses are like bypasses, but they're natural. They weren't. When we do a bypass surgery, we create anastomoses, but they're just other pathways for blood to go. So if blood wants to get from this point to this point over here, it can take this pathway, or it can take this pathway. You know, these are different pathways that the blood can take, or it can take even a more inferior pathway this way. So anastomoses just create different pathways, and if there's a blockage, if there's another route that the blood can take, it's a less chance that you're gonna have a heart attack. So anastomoses are good, and from what I can remember reading, you can Google this if you want to, but exercise, cardio exercise, actually helps your heart to generate more anastomoses naturally. And that would be very good for you, if you did have a blockage. So let's see, we have also running right through here is the right coronary artery. And then we have the anterior cardiac veins here and here. I already showed you the great cardiac vein. On the posterior side of the heart, you can see the circumflex artery. We saw it beginning here, and then it comes back around. We can see the great cardiac vein, which follows kind of along the same pathway in the coronary sulcus. That little groove in there between the left atrium and the left ventricle. And it enlarges into the coronary sinus. Okay, so we have the middle cardiac vein, and then we have the right coronary artery that we can see here. Okay, so just a few, just to show you some of the major ones that you would see. Okay, so a heart attack, the medical term is a myocardial infarction, and it's defined, the definition of a heart attack is an area of dead tissue in the heart muscle. Oh, actually, I'm sorry. An area of dead tissue in the heart muscle caused by the heart attack is an infarct, and that's why myocardial infarction is heart attack. And heart attack is caused by an interruption in blood flow, some kind of a blockage in the coronary arteries, often as a result of coronary artery disease. So, damage to the semilunar valve of the right ventricle would affect blood flow into which vessel? So the semilunar valve of the right ventricle is the pulmonary valve. So it would affect blood flow into the pulmonary trunk, which branches into the pulmonary arteries. Then why is the left ventricle more muscular than the right ventricle? We discussed this. That's because the left ventricle has to pump harder, because the right ventricle is only pumping blood to the lungs and the left ventricle is pumping to the systemic circuit. Now, I do want to go over the basically the conducting system of the heart. So the heart has its own it regulates its own, it kind of has its own auto regulation. It's an automatic system that's caused by these nodes and this nodal tissue, which is like nervous tissue. So the pacemaker cells are located here in the SA node, which is in the upper end of the right atrium. And so the electrical impulse starts here, and then the electrical impulse travels through the right atrium to through the nodal cells anyway, to the AV node. Okay. Then from the AV node into the AV atrioventricular bundle, and then the bundle branches. And those branches travel down the interventricular septum. There are two of them. And then you have the Purkinje fibers, which now they have a different name, but for our purposes, we're going to call them Purkinje fibers. But anyway, the Purkinje fibers kind of send the electrical impulse all the way up through the rest of the heart muscle tissue. So that the SA node is the pacemaker of the heart. And these electrical impulses are measured with an EKG. And so we'll look at the EKG in just a minute. You do need to know these terms, they're medical terms. Bradycardia is a slow heart rate, slower than 60 beats per minute. Tachycardia is faster than 100 beats per minute. And you also may hear this term ectopic pacemaker. And this is when abnormal cells generate action potential so quickly they override those of the SA and AV nodes. And in that case, someone may have to have surgery. So we've got the EKG or ECG, which stands for electrocardiogram, is a recording of the electrical events of the heart. So every time you see a blip, every time you see a peak in the EKG, that represents something that's about to happen. Something's about to contract or something's about to relax, but something is about to happen in the contraction cycle of the heart. We use EKGs to diagnose cardiac arrhythmias and abnormal cardiac activity. You cannot use an EKG to diagnose a heart attack, but you can tell if the heartbeat is too fast or too slow. You can use it for bradycardia and tachycardia and other things. There are other conditions too. So the first little blip is a P wave, and it indicates atrial depolarization. What that means is the atria of the heart are about to contract. After that impulse travels through the atria, they're going to contract and pump blood into the ventricles. So the P wave represents atrial contraction, atrial depolarization leading to contraction. Then there's the largest peak, which is the QRS complex. That indicates ventricular depolarization, which means that the ventricles are about to contract and pump blood out of the heart. What is hidden in the QRS complex is the atria are relaxing, and that's atria repolarization that leads to the relaxation of the atria. Then you have a T wave that indicates the ventricles are about to relax, and that's called ventricular repolarization. And you can look here, here's your P wave, the atria are about to contract. The QRS, the ventricles are about to contract. The T, the ventricles are relaxing. All right, questions? Checkpoint question 5. If the cells of the SA node did not function, how would the heart rate be affected? And it would be slowed because the SA node sets the heart rate, and it's faster than the rate that the AV node would set the heart rate. So if the SA node stopped working, then the AV node would kind of take over, and it's going to cause the heart rate to be slowed down. All right, number 6, why is it important for impulses from the atria to be delayed at the AV node before they pass into the ventricles? That gives time for all of the blood from the atria to empty into the ventricles before the ventricles contract and before the closing of the AV valves. So it gives a brief little delay so that all that blood can leave the atria and enter the ventricles, and then the AV valves can close before the ventricles actually contract.